You're standing right there at the bedside. You're a brand new nurse. Your charting is finally caught up. Your stethoscope is untangled from your badge reel. And then, without any warning at all, the patient's monitor just starts flashing red.
Oh, yeah, that high-pitched, terrifying, sustained alarm.
Exactly. And your stomach just drops instantly.
It's really the exact moment where all that theoretical knowledge you have violently collides with reality. Because, you might remember the colorful textbook diagrams of the heart perfectly.
Right. Like you can visualize the flashcards in your head.
Right. But looking at the actual human being sweating in the bed right in front of you, none of that classroom knowledge automatically tells your hands what to do next.
It's the paralysis of the new nurse. There's just this massive gap between reading in a library and making a life-saving decision in a hospital room. And closing that gap is exactly why we're here. So welcome to an episode of the Super Nurse Podcast, which is created by Brooke Wallace. Now, for those who don't know, Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
And we should definitely clarify immediately that we are not Brooke Wallace.
No, not at all. But this entire episode is constructed directly from her bedside clinical notes, her real-world practice, and her signature teaching style. We're basically unpacking her brain to help nursing students and new nurses translate what they know into real, confident patient care.
Yeah, and our mission today is to decode the human heart. We're going to look at how it works, how it interacts with the lungs, and most importantly, how to actually assess it confidently when things go wrong on the floor.
And real quick, before we get into the anatomy, we want to invite you to subscribe and watch the video version of this episode on YouTube. The link is in the description. Just head over to our channel called Super Nurse AI.
All right, so let's build a foundation here. To figure out why a pump is failing, we first have to understand how it routes fluid when it's, healthy.
Makes sense.
What we know from practice and what clinical experience shows is that it really helps to simplify the heart's anatomy initially by thinking of it as a two-room house.
Okay, a two-room house.
Yeah, so you have a right side and a left side, and they're divided by this thick wall called the septum.
I always like the two-room house concept for flow. Even if houses don't actually squeeze, but let's map it out. The right side of the house is dealing entirely with deoxygenated blue blood, right?
Exactly. This is the blood returning from the body after all your organs and tissues have extracted all the oxygen they need.
And it dumps into the right atrium through those two massive pipes, right?
Oh.
The superior vena cava from the upper body and the inferior vena cava from the lower body.
Right. And from that top room, the right atrium, the blood drops down into the basement room, which is the right ventricle. And here is where the first major action happens.
Squeeze.
Yeah. The right ventricle contracts, and it pushes that deoxygenated blood out through the pulmonary artery straight over to the lungs.
So the right side of the heart is kind of like the local recycling center. It just takes the used blood, shuttles it next door to the lungs, drops off the carbon dioxide, and picks up fresh oxygen.
That's a perfect way to put it. And once it's refreshed at the recycling center, it travels back to the left side of our house.
Returning bright red and highly oxygenated.
Yeah, via the pulmonary veins. It enters the left atrium, drops down into the left ventricle, and then gets forcefully pumped out to the entire systemic circulation.
Through the aorta, right. The largest artery in the human body.
You got it. And that left ventricle is doing the heavy lifting.
Well, yeah, because when I look at those anatomy diagrams, the first thing that jumps out is just the sheer physical difference between the right and left ventricles. The left ventricle, the big mama of the heart, is massively thick compared to the right side.
Mechanically, that makes perfect sense, though. The right side only has to gently push blood a few inches over to the lungs. The pulmonary vascular resistance is very low.
But the left side has a completely different job.
Exactly. It faces a completely different mechanical challenge. It has to generate enough sheer force to push blood against systemic vascular resistance. It's pumping against gravity up to the brain and through miles of peripheral blood vessels all the way down to the toes.
Which obviously requires a vastly thicker, stronger muscle wall.
Right. And securing all of this directional flow are the valves, because we cannot have blood washing backward.
Right, the valves are the one-way doors. And I know every nursing student learns the classic mnemonic to pass their exams. Toilet paper, my aorta.
Tricuspid, pulmonic, mitral, and aortic.
Exactly. It just helps you remember the order the blood passes through them.
Yeah, mnemonics are great to get you through the exam, but on the floor, the clinical implication of those valves is what really matters.
Give me an example of that.
So the mitral valve, for example, is the one-way door between the left atrium and left ventricle. If that valve fails, like if it blows or becomes incredibly leaky, that high-pressure blood from the left ventricle shoots backward.
Oh, wow. Which means it shoots straight back into the lungs, flooding them almost instantly.
Exactly. And that takes it from a textbook anatomy question straight to a bedside emergency.
And the sheer speed of this normal cardiac cycle is staggering to me. I mean, the atria fill, they squeeze blood down, and the ventricles powerfully contract, slamming those one-way doors shut behind them. Do you know how long that takes?
It's fast.
It's 0.8 seconds. That entire sequence takes just 0.8 seconds.
It's an absolute engineering marvel. But, if the left ventricle is doing all this massive heavy lifting, generating all this pressure to feed the body, we have to look at how the pump itself gets fuel.
Right, because the heart muscle is entirely full of blood, but the muscle wall is far too thick to just absorb oxygen from the chambers it contains.
Yeah, it can't just drink from the pool inside. It needs its own dedicated plumbing system.
The coronary arteries. Exactly. They branch off right at the very base of the aorta, catching the freshest, most highly oxygenated blood immediately as it leaves the pump. And they wrap around the outside of the heart like a crown.
And there are specific branches that you're going to track constantly in bedside practice.
Oh, absolutely. The left coronary artery is critical. It branches into the left anterior descending artery, or the LAD, which runs right down the front of the heart.
Supplying the bulk of that massive left ventricle.
Right. And the other main branch is the circumflex artery, which wraps around to the back.
Now, in clinical practice, you always hear the LAD referred to as the widowmaker.
Yeah, and the mechanics of why are terrifying. If that specific pipe gets clogged, the main pumping chamber of the heart loses its oxygen supply.
And that's a myocardial infarction, or an MI.
A heart attack.
Exactly. When fatty plaque builds up on the walls of these coronary arteries, the vessel narrows. But the acute emergency really happens when that plaque ruptures.
And then what happens? The body's coagulation cascade reacts to the rupture by immediately forming a blood clot right there in the artery. So the pipe is suddenly and totally occluded. The heart muscle literally begins to suffocate.
Which is why the guiding principle we always hear is minutes equal muscle.
Because over 500 cardiac cells can die every single minute during a total blockage.
Wow.
Yeah. If they're deprived of oxygen for too long, they move from ischemia, which is temporary starvation, to necrosis, which is actual tissue death.
And dead tissue turns into stiff, non-functioning scar tissue that will never contract again.
Exactly.
I really want to talk about how this actually looks when you walk into the patient's room, though. Because if you open a textbook, they hammer home the phrase, crushing left substernal chest pain radiating to the left arm.
The classic elephant sitting on my chest.
Right. But if I'm a new nurse and I'm solely looking for that one specific presentation, I'm going to miss a lot of dying hearts.
Relying exclusively on the textbook symptom is a massive clinical trap. Yes, some patients have that crushing pain, but the reality of bedside presentation is highly variable.
Right. Clinical experience shows it can look totally different.
Exactly. You might have a patient complaining of jaw pain or, a dull ache in their mid-back between their shoulder blades. They're often profoundly diaphoretic, just drenched in a cold, clammy sweat and looking really pale or dusky.
And we have to completely shift our assessment expectations for diabetic patients and women, don't we?
Oh, absolutely. Diabetics frequently experience what we call silent MIs, and there's a clear physical mechanism for this diabetic neuropathy.
Because chronic high blood sugar damages the nerve endings throughout the body.
Right. Those damaged pathways literally cannot transmit the classic crushing pain signals to the brain. Their heart muscle is actively dying, and they might feel nothing more than a vague sense of unease.
That's terrifying. And what about female patients?
Female patients are another critical population where the textbook completely fails us. Women often present with sudden, profound fatigue that they just can't explain.
Like they just feel exhausted out of nowhere.
Exactly. They might have unexpected shortness of breath or what feels like severe indigestion and heartburn. So they often brush it off, thinking they just overexerted themselves or ate something weird.
So if you're waiting for an older diabetic female patient to clutch her chest and fall to the floor, you will absolutely miss a lethal infarction.
100%.
Which brings us to the math of the pump. Because if an MI kills part of the muscle, the pump gets weaker. How do we measure that weakness?
This dives into hemodynamics.
And I know the word hemodynamics makes a lot of nursing students want to just hide under the desk.
It sounds super intimidating, I know, but at its core, it's just measuring flow and pressure. The central concept is cardiac output.
Which is normally about 4 to 8 liters of blood per minute, right?
Yep. And the equation is incredibly simple. Cardiac output equals heart rate multiplied by stroke volume.
Okay, so heart rate is simply beats per minute. Stroke volume is the actual volume of blood ejected with one single mechanical squeeze.
Exactly. But here's where we need to connect the math to the bedside symptoms. If a patient has a massive MI and their left ventricle is now full of dead scar tissue, what happens to their stroke volume?
It's going to plummet because the pump is weak.
Right. And when stroke volume drops, cardiac output drops. The body senses this immediately. Baroreceptors in the arteries detect the drop in blood pressure and send panic signals to the brain.
So the sympathetic nervous system kicks in, dumping catecholamines like adrenaline into the blood.
And what does adrenaline do?
It spikes the heart rate.
Yes. The body is desperately trying to compensate. If the streak volume part of the equation goes down, the body ramps up the heart rate part of the equation to try and keep the total cardiac output stable.
Oh, wow. So this is exactly why a patient with a failing heart often presents with sudden, unexplained tachycardia.
Exactly. But to fully grasp stroke volume, we have to translate two other clinical terms that freak people out, preload and afterload.
Okay, let's break them down into plain English.
Preload is fundamentally about volume and stretch. It's the amount of venous blood returning to the right side of the heart, filling up the chambers.
So the more blood that flows in, the more the cardiac muscle fibers stretch right before they contract.
Right. And afterload is entirely about pressure and resistance. It's the physical force the left ventricle must push against to pop open the aortic valve and move blood into the systemic circulation.
Okay, and contractility is the intrinsic mechanical strength of the muscle fibers themselves during the squeeze.
Exactly.
I always struggled with preload and afterload until I heard the water balloon analogy. It's just so helpful.
Oh, that's a great one. Go ahead and share it.
So imagine a water balloon attached to a faucet. You turn the water on, and the balloon fills and stretches. That stretch from the incoming volume is your preload. But then you take the balloon off the faucet, and you tightly pinch the knot at the end. Afterload is how tightly you are pinching that knot. If you pinch it really tight, which represents high systemic blood pressure, you have to squeeze the balloon incredibly hard to force any water out.
That analogy is excellent for visualizing pressure, but we do have to remember the biological reality here. Unlike a rubber balloon, the heart is living tissue.
Right, it adapts.
Yeah, so if it constantly faces a high afterload, say the patient has untreated hypertension for 10 years, the left ventricle actually remodels. It undergoes hypertrophy.
The muscle gets vastly thicker to fight that high pressure.
Which sounds good, like it's getting stronger, but a thicker muscle actually leaves less room inside the chamber for blood to fill.
So it creates a stiff, bulky pump that holds less volume.
Exactly. So how do we intervene at the bedside? If that afterload resistance is too high, we need to loosen our grip on the knot of the balloon.
And we do that with medications, right? Like AC inhibitors.
Yeah. Yep. The drugs ending in pril, like lisinopril. ACE inhibitors are brilliant because they interrupt the hormonal pathways that cause blood vessels to constrict. They cause systemic vasodilation.
They're essentially a chill pill for the heart. By dilating the vessels, they drastically drop the blood pressure. The afterload plummets. Now, the damaged left ventricle doesn't have to work nearly as hard to push the blood forward.
Exactly. But, if we don't intervene or if the muscle is just too damaged, the pump inevitably fails. And the cardinal rule of any plumbing system is that when a pump fails, fluid backs up.
Which leads us to the clinical realities of congestive heart failure. And because the heart has two sides, it can fail in two distinct ways.
Let's start with left-sided failure. If the left ventricle is weak, it can't push blood forward to the body, so the fluid backs up exactly the way it came in.
It backs up through the pulmonary veins directly into the lungs.
Right. And at the bedside, you will literally hear this backup. When you place your stethoscope on the patient's lung bases, you will hear crackles, the sound of air popping through fluid.
And the patient's going to feel terrible.
Oh, yeah. The patient will experience dyspnea or severe shortness of breath. They'll often have orthopnea, which means when they try to lie flat, gravity spreads that fluid across the entire lung field, and they feel like they are actively suffocating.
And the ultimate terrifying red flag of left-sided failure is pink, frothy sputum.
Yes, that is a massive red flag.
We learn to look for it, but the mechanism behind it is really fascinating. The hydrostatic pressure inside the tiny pulmonary capillaries gets so intensely high from the backup that it physically forces blood plasma and red blood cells across the membrane and right into the alveoli, the air sacs.
And when that fluid and microscopic blood mixes with the air the patient is frantically trying to breathe, it whips into a pink foam.
That's
It
horrifying.
really is. If a patient is coughing up pink, frothy sputum, they're in acute pulmonary edema. They're drowning from the inside out, and it requires immediate aggressive intervention.
Now, contrast that with right-sided heart failure. If the right ventricle fails, it can't push blood forward into the lungs. So the backup travels the other way, down the superior and inferior vena cava, pooling into the systemic venous system.
The bedside physical assessment looks entirely different for this. The lungs might sound perfectly clear.
Right.
Instead, you'll see peripheral edema, massive swelling, pooling in the lower extremities due to gravity. You will often feel hepatomegaly, which is an enlarged, tender liver, because the hepatic veins are gorged with backed up blood.
You'll see ascites too, right?
Right.
Which is fluid weeping into the abdominal cavity and just rapid, unexplained weight gain.
Exactly. Now, one of the most vital assessments for systemic fluid overload is checking for jugular venous distension, or JVD.
Where you're looking for a bulging, engorged vein on the side of the neck.
Right. But to assess this correctly, the physics of positioning really matter. The head of the bed must be at exactly 45 degrees.
Why exactly 45?
Because if you lay a patient completely flat, gravity keeps the blood in the head and neck, and the jugular veins look distended in almost everyone. It's a false positive.
Okay.
And if you sit them bolt upright at 90 degrees, gravity rapidly drains the veins downward, hiding the backup.
So 45 degrees is the diagnostic sweet spot.
Exactly. Normal veins should look flat there, but a failing right heart will force the blood column up, revealing a visible bulging rope in the neck.
Okay, so those are the external visual clues. But let's talk about the acoustic clues. How do we properly use our stethoscope to hear what the plumbing is doing on the inside?
We rely on auscultation, and the normal heart sounds, S1 and S2, the classic lub-dub, those are actually not the sound of the muscle squeezing.
Wait, really?
No, they're the acoustic shock waves of the heart's one-way valve snapping shut.
Oh, that's interesting. And to hear them best, nursing students learn the landmark mnemonic, all pigs eat too much.
Right. Aortic, pulmonic, Erb's point, tricuspid, and mitral.
But what's crucial to realize is that you aren't putting your stethoscope directly over the anatomical location of the valve itself. You're placing it downstream over the area where the blood is flowing to after it passes through the valve, because fluid transmits sound.
Exactly. And the mitral area, down at the fifth intercostal space, midclavicular line, is also your apical pulse.
And clinical practice dictates a strict rule here. If you are administering a cardiac glycoside like digoxin, which powerfully alters heart rate and contractility, you have to auscultate that apical pulse for a full 60 seconds.
Yeah, you cannot count for 30 seconds and multiply by 2. You need the full minute to detect any subtle rhythm irregularities.
But beyond the normal lub-dub, a failing heart generates extra sounds, right? S3 and S4.
Yeah, and this is where the physics of sound transmission tell a profound story about the muscle. S3 occurs immediately after S2. The cadence sounds like lub-dubbin.
Okay, lub-dubbin.
Right. S3 is often called a ventricular gallop. The physical mechanism is a massive volume of blood rushing in from the atria and violently striking a very compliant, overfilled, dilated ventricle.
So it literally sounds like fluid sloshing in.
Exactly. It's a hallmark bedside indicator of acute fluid overload and exacerbation of heart failure.
Now, S4 is entirely different. It happens right before S1. And while some people describe it as a horse galloping, I think of a mechanical metaphor for this one.
Oh, let's hear it.
Imagine trying to use a hand pump to force air into a car tire that is already massively overinflated and rock solid.
Oh, that is an incredibly accurate way to visualize it.
When you push the pump handle down, it physically shudders and bounces back against the stiff resistance. That's an S4.
Right. The atria are forcefully contracting to push blood into a left ventricle that is stiff, hypertrophied, and highly resistant to filling.
Usually from years of chronic hypertension or heavy scar tissue from a past MI.
Exactly. The shuddering impact creates that extra low-frequency sound.
And detecting those low-frequency sounds requires knowing your equipment. The stethoscope is a precision tool, but only if you use the right side of the chest piece.
Which brings us to the classic cool chicken memory trick.
Yes. As a student, I constantly flip my stethoscope back and forth, completely unsure of when to use the bell versus the diaphragm.
The cool chicken clarifies the physics. You use heavy pressure for high-pitched sounds, utilizing the flat diaphragm. Heavy, high diaphragm.
Got it.
Conversely, you apply light pressure for low-pitched sounds, using the smaller cup-like bell. Light, low, bell.
That makes so much sense.
And if you press the bell too firmly against the skin itself stretches tight and acts like a diaphragm, completely wiping out the low-pitched S3 or S4 murmurs you're trying to find.
It's all about technique. So we've covered the map of the two-room house, the critical plumbing of the coronary arteries, the math of stroke volume and heart rate, the devastating backups of heart failure, and the acoustic physics of the S3 and S4.
That's a lot of ground.
It is. But what does this all mean when you are actually standing on the floor?
It means understanding that the glowing monitor above the bed, the continuous EKG rhythm, and the troponin lab values are incredibly sophisticated tools, but they are just tools. They're isolated data points.
Because context dictates everything. Like if I look at the monitor and see a heart rate of 38 beats per minute, I might panic.
Right.
But if my patient is a 22-year-old elite marathon runner, 38 is likely their baseline. Their heart muscle is so powerfully conditioned that their stroke volume is massive. They can perfuse their entire body with far fewer beats.
But if you see that exact same heart rate of 38 in a 70-year-old patient who suffered an anterior wall MI 3 days ago, the context is lethal.
Because their stroke volume is critically weak.
Exactly. A rate of 38 means their overall cardiac output is completely crashing. Their organs are starving. They need immediate pacing and intervention.
The machine gave you the exact same number, but the clinical judgment came entirely from understanding the human being attached to the wires.
Which, leads to a fascinating question about the future of our profession. I mean, we spend years refining our physical assessment skills, learning to tilt the head of the bed to exactly 45 degrees to spot JVD, or using the cool chicken trick with the bell of a stethoscope to hunt for a subtle S4.
Right, the mechanical physical touch of nursing. But with the explosion of continuous biometric wearables, AI-driven predictive algorithms, and non-invasive hemodynamic monitoring, you have to wonder where the field is heading.
It's changing fast.
Will the bedside nurse of 2035 still be hunting for acoustic murmurs with a piece of tubing in their ears? Or will a sensor patch alert us to a drop in stroke volume 12 hours before the fluid ever backs up into the lungs?
Technology will undoubtedly shift the timeline of detection. But no algorithm can hold a patient's hand, calm their terror during an acute MI, or visually connect the dusky color of their skin with the look of sheer exhaustion in their eyes.
The human element.
Exactly. The tools evolve, but the core of clinical judgment remains human. You have to treat the patient, not the monitor.
That is the perfect takeaway. Thank you so much for joining us today. We highly encourage you to watch the video version of this discussion on YouTube. Please like, subscribe, and drop a comment below with your own bedside experiences.
And make sure to visit supernurse.ai for incredible resources designed specifically to help you bridge that terrifying gap between nursing school theory and real-world hospital practice.
You have the knowledge in your head. Now you just have to connect it to your hands. Keep looking at the patient, keep listening for the clues, and remember, the next time that monitor starts blaring, look at the screen for a second, but then look directly at the person.